Okay, great. So this is number 5 of the case reviews. Thank you so much, Saoirse, for covering the last 2 whilst I was on annual leave. Really, really appreciate that. And I know that there was some really good feedback from those 2 sessions as well, that people have told me whilst they've been away. Just to remind everybody that this session, we are protecting confidentiality of the patient. We're not here to judge any decisions that were made. We're here to have a discussion as part of the NDT team, so that we can do some future learning for those that were involved in this case. And if anybody finds this case difficult or would like to speak to me about it afterwards, then please do come and find me or contact me via email. Perfect, so let's start. So our maternal history, can everybody just confirm, can everybody see my screen?
Yes, we can.
Yeah, sorry. Lovely. So you've got a 24-year-old primate, gravida 1 paranaut, 39 weeks and 4 days admission. She has a BMI of 28. She's asthmatic on inhalers. Her bloods, she is A positive. Virology and scat is NAD. Last HB prior to on admission was 101. Platelets 302 and white cell count 11.4. I'll discuss a bit more about her pregnancy history in just a second. But her ultrasound at 34 weeks and 3 days showed placenta posterior high, normal fetal growth and Dopplers and normal fluid as well. And she's a beta thalassemia carrier. In her pregnancy at 34 weeks, she had a postcoital bleed of 300 mils, was admitted to our antenatal ward and was given a pharyngect infusion as her HB dropped down to 89. At 38 plus 4, she had her first episode of reduced fetal movements. The lady was sent round to triage following her antenatal appointment with her case midwife, because she reported this in the appointment. And the plan was made as they'd returned to normal whilst in triage that they wanted to repeat it the following day. And didn't feel the need to do anything more at that moment. And then at 39 weeks and 4 days, she came in again via triage with reduced fetal movements, had a SPR review and was offered immediate induction. She went home to gather her things and then came back and the induction process was started. Does anybody have any questions regarding her antenatal care?
Yes, so the 34-week appointment where she had the APH, was there a speculum, and did they determine whether it was sort of coming from the cervix because of the postcoital, or did they rule it out and just assume placenta?
So they from what was confirmed on the speculum, it was purely a postcoital bleed coming from the cervix, I believe.
Okay, thank you.
Yeah. And
sorry,
go on.
Do we have a CTG from the triage view before the induction has started, just so that we can know the baseline of the baby?
Not on this slide, no, but the baseline from the baseline from both her 34 week, but from her reduced fetal movements at 38 weeks was completely almost identical to the baseline at 39 weeks.
Okay, thank you.
Just quickly, Cara.
Yeah.
300 mils is according to whose estimation? Like our estimation in triage, or what she said at home? Like who said 300?
That was confirmed in triage. I think she gave a photograph of the bleed, and that was what was estimated, but it wasn't measured specifically in the hospital.
Okay, so this is based on a picture she gave.
Yeah.
Okay, all right.
Perfect. Any other questions about that at all? Cool. So I'll move on. So this was her admission CTG. This was taken on the 5th. At 22:24, her CTG was commenced. At 0000, Propus was inserted and her Bishop score at this moment in time was 0. Everybody happy with the admission trace?
Yes. So it's like a normal one.
I'm sorry, but what was the baseline here? I can't see.
140, 135, 140.
Okay.
Perfect. So everybody's happy, yeah? Good accelerations, good variability. There was no reported contractions or tightenings at this moment in time, but I think she was having some sort of irregular tightenings anyway, as what's reported on Cerner, as you can sort of see there on the TOCO. So yeah, Propus was inserted at 0000, which is on this trace here, and then it's also just sort of documented there as well, although it's documented in the wrong place on the CTG, might I add. But yeah, CTG was discontinued at 0013, so only 13 minutes following Propus.
Is it the usual practice that only 13 minutes or
No.
just... Okay.
No, so that was one of my sort of key messages as part of the CTG review, was actually our recommended length of duration following any kind of prostaglandins is a minimum of 30 to 40 minutes. Correct me if I'm wrong there, but normally we would routinely try and keep them on the CTG for up to an hour post prostaglandin insertion.
Because also we can't use those Redmond, as I know.
Yeah.
If we're using prostaglandins.
Absolutely.
So just a question about the usual practice. When do we stop it, or there's no guideline for that?
So there is, as far as I know, there is a guideline that basically when it comes to induction, you're supposed to keep the baby on the monitor for a minimum period of 40 minutes following any kind of prostaglandin insertion. So that's Propus or Prostin.
Thank you, Cara.
So that's the latest CTG. So that goes on at 0013. That's when it's discontinued. Overnight, no CTGs were performed at all, and so on the 6th there was a period of 10 hours and 35 minutes where this patient did not have a single CTG trace overnight. Undocumented and unfound when I was rummaging amongst her paper notes as well. So another key point I wanted to point out in this case specifically is that for any kind of reduced fetal movements induction, or majority of our inductions, we should be doing them 4 to 6 hourly, depending on registrar review. So yeah, 10 hours and 35 minutes isn't particularly acceptable in terms of our practice.
Was there any documentation in regards to why that might have been? So human factors element, or there was a busy night, short staffing, there was an emergency, she got pulled to another ward. Was there anything else documented potentially why?
Nope, there was a few check-ins documented. Patient was asleep or patient up to toilet, but other than that, there wasn't any reason documented for why there was no CTG performed in this time frame.
Okay, thank you.
So at 10,
was there a registrar review when it comes to that induction, or?
Yeah, so the registrar review was done in triage.
Okay.
So when she was taken to triage in the afternoon of the 5th, and that's when the plan was made. And as far as I'm aware, that's when she was transferred over to Hope Ward. She was admitted to Hope Ward. Plan was made. The medication was prescribed, and the plan was in the triage documentation note. But she wasn't reviewed by an obstetric registrar overnight. It was just the following morning, which was when the next registrar review was. And that, I believe, was about 10:30 a.m. So just before the CTG was recommenced. Yeah. So 10:44 CTG was recommenced, and this client's now contracting 1 to 2 in 10, and was classified as a normal trace. I've got the trace on here as well. At 12:30, she shrum, clear liquor. A VE was performed, and she was found to be 1 centimeters. Propus was to remain in situ. 13:10, pethidine was given upon client's request as she was becoming more uncomfortable. And then at 1700, CTG was recommenced and she was contracting 2 in 10. Sorry, I apologise. I don't have the CTG from there, but it was normal. My mistake. So yeah, this is her 1700 trace.
So just a quick one, Cara, and this is for all my colleague midwives and registrars present. I completely agree that after SHROM, if the contractions are not settled yet, to leave the propus in.
Yeah.
Because I was asked about this by somebody in labor ward, I can't remember when, and maybe there was eyebrows. Why would we leave the propus in? Which I would say I would leave it in, but not more than 6 hours after the SHROM, really. So as if I am treating it as a SHROM now. And I'm doing a 6 hours induction followed by Cinto or whatever. So I wouldn't leave it forever, but I would leave it, but under close observation, personally. So if
Mr. Naguib,
somebody, yeah.
Will that cause hyperstimulation at that point? Because I saw a couple of patients like that when we left the propus in after SHROM, and I brought them to labor ward because of hyperstimulation at that point. So will that
Not on a routine base. That's why I'm saying close observation on that continuous CTG at this point, because she might go into hyperstimulation, but not because particularly that because she's SHROMed, partially yes, but maybe because what caused the SHROM is the contraction, and the SHROM itself has caused the release of prostaglandin, so it increases the contraction. So that's why you can continue under close observation, not leaving them, because there is a possibility of hyperstimulation.
Thank you, sir.
Thank you. So this is the so she's SHROM now 12:30. Pethidine was given, and at 5 p.m. CTG was recommended since she's contracting 2 in 10. So this is the trace. This is the trace now. At this point, she's still contracting 2 in 10, and they are palpable. Observations at this point were completely normal as well. But baseline has reduced from the prior baseline down to sort of 120. And then at around 1750, as you can see, we had quite a lot of loss of contact, and audible decelerations were documented in the Cerner notes. At 1755, an examination was performed by the antenatal ward midwife. She was found to be 4 centimetres and then was transferred over to labour ward. Everybody agree with this plan?
Why terbutaline was given?
Because of the audible decels is what's documented, although because it's very difficult to analyse the CTG trace.
Was the propus removed?
Yeah.
So propus removed and terbutaline.
Yeah.
Okay, that's acceptable. Yeah.
Yeah.
Due to audible decelerations.
Yeah, audible audible decelerations, yeah. Anybody disagree with the plan of care?
I was just going to ask about the contractions, and that's why I was asking about the terbutaline. And we don't have any documentation on the CTG for any decelerations or even the documentation for the contractions. That's why I was asking.
Yeah.
Was there anything in the documentation?
So the documentation just explains that she was contracting sort of 2 in 10 around the time frame, but that was reported at 5:30. But in this time period here, we've got from 5:30 to 6 p.m. There wasn't a specific amount of contractions documented on Cerner. No.
And if you review this trace, Omar, you can see that there is a loss of contact. Most likely, what I can read this CTG at the last bit of it is more of a decrease in the baseline and hyperstimulation. So for me, terbutaline is a short-lived drug. To give it, remove the propus, transfer to labor ward, you are erring to the side of caution. So this baby doesn't have a hypoxic insult.
And I'm
If
not
you,
against the
yeah,
terbutaline.
no,
I
what
was
I'm
just
saying,
asking about the
what if you, what I want to say is if you start analyzing how many contractions, is she contracting or not? Is she this? Is she that? Is she that? It will be a waste of time till you give it, like in this situation. So I think, yeah, I think in the bigger scheme of things, at the end of this trace, there is lots of saltatory pattern where the baby is struggling with the contraction. So the best is I have a background. So in my head, if I am reviewing this, I have two backgrounds. One is TROM and propofin, and one is a bleed at 34 weeks. So in my back of my head, I'm thinking that there is also possibility of abruption. So then the question arises, oh, in abruption, will you give terbutaline? If she is contracting and you are transferring to theater, it is not contraindicated.
Yes, but Mr. Naguib, is it right for us to give terbutaline without any kind of assessment or documented evidence that this is hyperstimulation? Because as you said, if anyone is thinking of abruption and you give her terbutaline, you're dooming this baby for death, because the uterus will relax, the abruption, which is probably concealed behind the placenta, is going to expand, and then you're doomed. So
Yes.
I think here I can criticize giving the terbutaline without any evidence, neither of CTG nor of proper assessment. Because if in the back of the head we are thinking of abruption given the history, and you give terbutaline, you relax the uterus and then you expanding the abruption.
You are not expanding the abruption
When you give terbutaline and on the suspicion of abruption, you will.
Yes, no, this is if this is abruption. What I'm saying is somebody who bled at 34 weeks, who had a minor placental separation, let's say, and who is contracting very strongly to the point that she is decelerating and being saltatory. Yes, if she is a true abruption and she is bleeding, I agree with you. But if she is 34 weeks, we are now more than 5 weeks since then. We are not talking here abruption. We are talking more of a hyperstimulation from the propus and the rupture of membrane. So it is more of, I am more treating the contraction till I transfer from an environment of hope ward to the labor ward, or if I'm transferring from labor ward to theater. Yes, if it is a florid abruption, I don't disagree, but if it is abruption, wouldn't it have shown in the liquor? Wouldn't it have shown in the when she is now 4 centimeter? So it is definitely not abruption. But what I want to say is we need to have it in the back of our mind that she might, in the process of this contraction, cause more separation of the placenta.
That was going to be my second question. Was
Yeah.
there any bleeding at that time, or
No, it was clear,
sign
like as they said.
Clear like all.
Yeah. Yeah.
and no signs of abruption at that point?
No.
That would answer Maya's question here, I think.
Yes. Yeah.
Cool. So at 1810, at 1805, the client was transferred over to labor ward. At 1810, terbutaline was given. And as you can see here, we've got much better contact now. So this baby was 100% recovering from these decelerations. At 18:25, consultant was present for review, did a follow-up VE and found the client to be 4 centimetres dilated and agreed with the previous midwife's examination. An indwelling catheter was inserted due to not passing urine in more than 3 hours. I believe 300 to 400 mils was passed. And then, as you can see here, the CTG continues. And pre-meds were given at 18:20. What do we think now?
I think it shows that it was an hyperstimulation at that point.
Yeah.
That the CTG normalized after the tibutylene, and I don't think that in the CTG also is it documented how many contractions, or are we palpating at that point, or are we putting the toku at that point?
This was purely on labour ward, and I think everybody, we're going to consider human factors here, and the fact that obviously she'd been rushed over quite quickly. There was an awful lot of people in the room that were doing things to support this woman and to try and recover the trace. The TOCO was ignored. There's no documentation of palpated contractions, but the TOCO was clearly placed on her abdomen. But yeah, as far as I can tell from the documentation, there wasn't any contractions recorded or palpated in this period of time after the sibutylene was given. And then the TOCO was readjusted at 18:30.
And what about the maternal pulse?
Maternal pulse was 80 at this point.
And just on the CTG, or just
that was palpated, and she had a Dynamap put on when she got into the room, and blood pressure, and that was normal as well. Sorry, Omar, I know you requested last time for more obs to be put on the CTGs, but there are some coming.
No, it's okay. I'm not again. I'm not. I'm just asking. I'm not. That's purely questions. They are not any. Yeah. Not. Yeah.
Perfect. So we're happy with the CTG normalizing now. Any concerns with this one?
Yeah, we are happy.
Happy? Yes. So at 18:30, the client was then becoming more distressed and requesting an epidural. She said that even though she sort of had a break from the tibutylene, and it had caused the contractions to sort of slow down, I think even she knew that there was an issue in the previous CTG just here at the end, because she reported quite excruciating pain at that point in time. And then, as you can see, at 18:30, when the contractions started picking up again, she was requesting an epidural. So moving on, this is her next CTG. Still no epidural at this point. Anaesthetist was called. However, I believe they were in theatre at the time, so were unable to attend.
And that's the baseline of 130, right?
Yeah, 125, 130.
I don't think this fetus likes the contractions. From after what Naguib had mentioned earlier regarding the saltatory and sort of shark tooth pattern, it sort of looks like a slightly irritable uterus maybe, and sort of some signs of uterine separation potentially, signs of a placental abruption, especially with her history as well. And the drop in the baseline. Correct me if I'm wrong. What do we think about that?
What did you say, Sosha? Sorry, your voice is a bit far away.
Sorry. Sorry. No, I was just saying, obviously there's been a slight drop in baseline. Sort of now we were 140, weren't we? Now we're sort of 125. You're starting to have more contractions. The contractions are picking up more to sort of the back end of this CTG trace. and I think it's from mention from Naguib earlier regarding sort of that pattern, sort of to me looks sort of sharp toothy, which could be potentially indicative of sort of bleeding or signs of sort of uterine irritability. What do you think?
And I think the maternal observation would have been changing if that's the case also.
Potentially becoming tachycardic.
Yeah, that's what I'm yeah. Again, Cara. Maternal.
There wasn't any obs done in this time period. That's why they're not on there.
Yeah.
Cool. So speak from what you've all sort of discussed on this one. Moving forwards now. What we're thinking about this one here.
Maybe it was just cycling and thumb sucking probably.
Yeah.
Yeah.
Looks like normalised.
Yeah, normal again.
Yeah. So yeah, good accelerations sort of peaking up now. So this baby's showing some good reassuring signs here. So in 1950, the anaesthetist arrived ready for an epidural and apologised due to the delay being in an emergency in theatre. So yeah, happy with this one, fantastic. Moving on to 20, so now it's 8:10. New staff have taken over. Sighting of epidural. She's now set up in position.
I was just about to say that whenever we're having a sort of a borderline CTG and you feel like you're slowly becoming a suspicious CTG, it might be normal beforehand, but having that sort of anticipating what's next approach, especially when you're going to do something like go to theatre for a spinal or an epidural, what are you anticipating is going to happen next? Obviously, this just looks like potential maternal pulse.
Yeah. So the reason I'm continually putting these, so I'm handpicking all of these CTGs, so the ones I find particularly interesting, but also the ones that I think we really need to learn from. This is now, I've kind of lost count of the amount of times I've reviewed these traces where we're actually picking up maternal pulse during the sighting of an epidural as opposed to the fetal heart rate. And considering the concerns we've had for the last good couple of hours with this fetus, with the terbutaline being given due to hyperstimulation and everything else included, I think the importance of getting our fetal heart rate accurately represented on the trace is so important. But sadly, we are continuing to see that we're not necessarily using this as a priority. And as I've said in previous sessions, we know that we love to support our anaesthetists as midwives. However, if you are struggling to do both at the same time, ask for help. Ask the ODP to come and support the anaesthetist should they need it. But actually, our priority as midwives in this situation is to ensure that we're getting an accurate representation of fetal well-being. Yeah. Observations again were all normal at this point. However, her temperature has now gone up to 37.5. This was the first recorded temperature for about 3 to 4 hours.
It might be worth just on the back of this epidural doing potentially a observational audit to see if there's any other reasons as to why people are finding it difficult to locate the fetal heart. So it might be that we're helping, but actually there might be another indicator. It might not be actually known that that's my job, especially with our new staff and supporting the new band 5s. Is it a case of actually learning? So it might be worth doing an observational audit just to potentially see.
Absolutely, I can definitely do that. Absolutely. Perfect. So like I said, new midwives have taken over. We're now at 2050. Test dose was given at 20:55, and as you can see, observations were normal, and the temperature came down to 37.3 in the space of 10 to 15 minutes. But otherwise, all obs beautiful. Again, I'm going to say the same thing I say every single week that I do these. If we're writing on the CTGs, either write above it or write it as a technical note, which will print out nicely and very neatly on the CTG, because actually when you're writing in between the lines of the fetal heart rate, it can be really difficult to sort of determine which bit's fetal heart rate and which bit's handwriting. But again, that's definitely something I can try and spread the word about across the unit, because it happens an awful lot. But following epidural, are we happy with the trace?
Yes.
Sounds just like
Yeah.
reassuring.
Perfect. So this is 2140 now. 2115, the registrar had reviewed and agreed normal trace. 2145, palpable contractions now 3 to 4 in 10, and normal trace was documented. And then at 2200, her observations again were normal. I've just put the blood pressure there, but the rest of them were absolutely fine. And then she had another top up of 5 mils at 2204 because she was becoming more uncomfortable. So the anaesthetist popped back in and readjusted and gave her an extra 5 mils top up. Thoughts? What we're expecting next?
When was the last VE?
At 1830. So as due for VE at 2230.
Has she got fluids running?
Yeah,
Good urine output?
yeah.
I can see some variable deceleration starting to happen.
Yeah, so we can expect more.
Yeah.
Yeah.
Especially with the top up as well.
Yeah. So this is the next half here. So 2205, she had a epidural top up of 5 mils. At 2225, an additional top up of 5 mils. And at 2230, she was found to be 4 centimeters dilated, and position minus, presenting part -2. She was moved to right lateral at this point due to the decelerations occurring.
What was the observations after the second top up? Because that's probably the reason why.
They were normal.
They were normal. Okay.
Yeah. So blood pressure was 116/73 at 2200, and then it was exactly the same, I think, for this
Second one.
yeah.
Yeah, we can continue then.
2240, CTG ran out of paper, and it took 15 minutes for the CTG to be recommenced. She was moved to left lateral following that audible decel you may be able to see at 2300, moved to left lateral, and then the CTG was continued there. She had yet another epidural top up at 2315. That's the 4th one now.
Just, this might be me being a little bit silly, but are we still doing the continuous epidurals? Are we doing bolus now?
Continuous.
We still have continuous. Okay, fine.
Yeah. The client was still uncomfortable. And CTG, the contractions weren't recorded in this duration of time either. And as you can see, they're not being picked up on the TOCO.
But how would we titrate the Synto if we have no contractions?
So at 2325, I think the registrar, the registrar came in for review, unable to palpate the contractions, and that's when it was decided that Synto was going to be started. Would we be happy to start Synto on this trace?
Yes, but personally, you'd want to make sure you're palpating that uterus, good resting tone. If you are having contractions, you're noting them. not necessarily relying solely on the CTG trace. You want your own sort of skill to know what that uterus is doing in between. Your baseline's dropped again to 120.
Yeah.
So it's gone even lower now. Now I know that could be potentially head compression, or was there any signs of an asynclitic head, or the position was sort of abnormal when they
not documented on VE.
So potentially it might be more well applied, but yeah, I think, I mean, from an obstetric point of view, when your baseline is dropping, sometimes that can be, correct me if I'm wrong, some head compression, and usually it's sort of a potential that she's coming up to delivery very soon. But with her history and the fact that she's uncomfortable and now we're starting Synto, I would anticipate this to get worse potentially, sort of wider, deeper decelerations, potentially leading to a prolonged deceleration. That would be my anticipation. So what to expect.
Yeah, do we agree?
Yeah, I think May's just agreed and said it could be a sign of head and eye compression. So I'm glad I'm not wrong there. Thank you.
So we're now at 23:30. Synto has been started at 3 mils per hour. And over the next 10, and then at 23:45, the client is having another 5 mil top up of epidural.
This is where the observations are very paramount here.
Yeah.
Like I've got a mystic ball. Good variability within them. So baseline's 120, good variability. What is she contracting? The Synto still on?
Yeah, they get to 2 and 10.
Synto still on 3 mils.
2 and 10, and we're still on the old 3 mils.
Yeah.
We didn't increase it, right?
No. So guideline would be increase every 30 minutes until it reached until we got regular contractions. So they wouldn't have done it until midnight anyway. But yeah.
The towards the end of this CTG trace, where obviously we're having the prolonged deceleration here, it states the maternal pulse is around 82 as well. Do we think potentially we're picking up maternal pulse here? It looks potentially like that from her observations.
Yeah, any other thoughts?
I think it's maternal pulse also.
Yeah. Mr. Naguib?
Yes, I agree. And even if we are suspicious, I think even if we are saying it is maternal or not, the best is to put an FSE, really.
Yeah, absolutely. FSE, and try and find a maternal pulse oximeter to put on the CTG trace as well, just so that we can determine which part of it is deceleration and maternal pulse.
Yeah, and for the baby's head.
And at that point, was there any bedside scan? Any?
No.
Because it's 1, 2, 3, 4, 5, 6 minutes at that point.
Yeah, 6 or 7.
Any emergency buzzers at that point? Any?
Did we follow the acute hypoxia protocol?
Yeah. So no bedside scan was performed and Synto wasn't turned off at this point when it reached the 3-minute mark, or when the possibility of deceleration was occurring. Maternal pulse wasn't recorded alongside the CTG when the heart rate obviously went decreased down to 80. So what happens next?
So as Maya is saying on the chat, as Omar is saying, this need to be followed as a 3, 6, 9, and so on. Yes, it is the maternal, but we need the midwife who is attending. Either she can adjust it to have a better fetal heart. Better is to call for help, put an FSC, and be sure, rather than having 7 minutes of not knowing what we are doing.
Yeah. So at 0003, the emergency bell was pulled. At 0004, an examination was performed and the client was found to be 6 to 7 centimetres. And at 0008, a decision was made for a category 1 caesarean section.
We didn't follow the 3, 6, 9, 12 approach. We
No.
didn't rule out.
Yeah. Yeah, this is definitely a rushed decision, in my opinion, and we didn't follow the protocol of trying to see if it recovers and so on. Cat 1 is an exaggerated reaction. Yeah.
Yeah. So no ultrasound scan was performed. Either, like I said, maternal pulse wasn't palpated at this point in time, so there was no way to determine whether or not this was fetal heart rate or maternal pulse. Obviously, given the history, I think, think about how we're going to be very cautious with this fetus. However, in order to sort of rule it out, there may have been things that we could have done to avoid it.
Before moving on to the next slide, just when you do have a prolonged deceleration or bradycardia, if you've got a CTG that's normal beforehand, it would reassure you in some sense that actually this fetus does have reserves.
Yeah.
And then you could have an opportunity to examine FSC and sort of a sit and wait approach. Because I'm assuming before you go to theatre, when you show the theatre CTG, we probably recovered. But then again, you're going to have, if you have got a compromised fetus, if you're going to put a spinal in, then you're going to have a further deceleration. So it's just, yeah.
Yeah, there is two things here, Socha, definitely. One is that the CTG was normal, not only normal, it was accelerative at certain points. So number one. Number two, category 1 section is denying her, when she progressed 3 centimeters in the last 2 hours, the chance to continue. Number 3, cat 1 doesn't allow, sometimes with the nerves and the adrenaline rushing, you are conveying this to the anesthetist, he will put her to sleep. And putting this lady to sleep will also affect the baby. So, I mean, in all aspects, we haven't done a favor to this lady.
But Mr. Naguib, I think they called for a Cat 1 section after more than 6 minutes of bradycardia. I know that the bedside scan was not done or maternal pulse was not recorded at that point. But if I called for Cat 1 section at that point, I'm following the 3 rule or the 3 minutes rule or 6, 9, 12. And the decision for a Cat 1 section can be changed in theatre. So
the rule applies, Omar, if I am monitoring the baby. It's not about getting somebody and saying, I am monitoring, but I'm not monitoring. You know what I mean? So if you are monitoring and then you are like seeing a deceleration, as you said, you have 3 options or 3 possibilities. 1 is abruption, 2 is cord prolapse, 3 is scar dehiscence. Neither of these are happening at the moment. So there is no true explanation why the baby should go down after a normal CTG. So to try to apply the same rules on a CTG that we are not monitoring rightly doesn't apply. I can understand if the adrenaline is running and you are rushing and you are going to reverse it in theater, if you are senior enough to reverse it. in many occasions, or let's say in many units, and at least 7 to 8 out of 10, once the patient goes to theater, it's not only that the decision is made, it's not only the anesthetist involved now and the ODP and whatever, the lady is completely terrified, petrified, that you already told her that your baby is going to die. So the reversal of the decision, although yes, logically speaking, yes, is not the easiest of the things that to happen in the middle of a dilemma like this. So it is better if I am taking the 369 whatever into account, is as you exactly said, put the scanner on. The same as I said, the same as Maya said, is put an FSC on. Make sure that it is truly this is fatal. Then okay, I'm not saying don't. But to make this based on this CTG, it doesn't make sense.
Perfect. So just to inform everybody, this client was rushed around to theatre for a category 1 cesarean section. A GA was performed and no theatre CTG was placed on the abdomen whilst she was in theatre. Does anyone want to guess the gases or the APGARs?
So this is exactly what I was saying. It was rushed, and the C-section. I think Maya has put on the chat 7.34 for her.
Oh, perfect. Oh, I can't see Maya's thing. So if anybody can read them out to me, that would be great.
Yeah, no, she said that she can't talk, so she is putting them on the chat.
Oh, okay, fab. So Maya said 7.34.
The gases might.
I think that the gases will be starting from 7.1 because of Mr. Naguib, what Mr. Naguib said. Also because we put a GA on a baby that, as you said, Mr. Naguib, it could be an acute event that would be.
But in this situation, Omar, so far, and I'm just reiterating just in case what I said earlier was not understood well. What I said about the abruption and the back of my mind, I am not thinking abruption. If you are thinking abruption, yes, you don't give terbutaline. But what I'm saying is, in the back of your head, you are thinking of possible abruption in the course of action. So here I cannot see the abruption, Omar. I cannot see it. You know, there is no bleeding. There is no, she is contracting. There is no rockwood abdomen. It doesn't fit.
There's a resting tone.
Yeah, so I am going again above 7.26, 7.28 with normal APGARs despite the GA. But I mean, yeah.
Perfect.
It doesn't, yeah.
So APGARs were 9, 10, and 10. Gases, arterial pH 7.3, base excess minus 4.2, venous 7.31 pH and minus 2.9 base excess. Female infant, born strong, 3795 grams.
Not a small baby at all.
Normal centile for her, though, was under the 90th.
Yeah.
It's an interesting case to discuss because from some point of view, I know we've discussed it in quite a lot of length and we knew that it would have good outcome, but in some cases people may say, oh, we just saved the baby, or oh, we just caught the baby at the right time. So I think it might be good sort of reflecting back on this case with the staff and seeing their point of view. What else was going on delivery suite? Was there other stressful factors? And actually, because we had a lack of fetal heart rate, or there was other concerning things. It might be looking at sort of a reflection with the whole team as to why this now happened, rather than the fact that we just did it because we wanted to go over and done with. There might have been other things that the obstetrician was focusing on. There might have been something on gynae ward, or there might have been something on the antenatal ward. And this was a stressful case potentially. So it's a good one to review because I think it's brought out quite a lot of themes.
And that also was that happened also during a night shift also. Yeah, what you said, Sosha, could be right.
Absolutely. So yeah, we got the human factors there. You know, this baby was born in the middle of the night. We don't know what was going on at the ward at the time, so really do have to think about our human factors here. But I think this case has been a brilliant one for discussion because there's been a few key themes coming out of it, such as you know, making sure we've got fetal heart rate during an epidural. Obviously, the importance of regularly checking maternal pulse, specifically in these incidents, and also just reiterating our 3, 6, 9, 12 rule before we go into theatre for any kind of category 1 cesarean sections.
And a question, Cora.
Yeah.
All the CTG machines that we have has maternal pulse oximeter, right?
They all have the electrode that goes on them, but people do tend to sort of steal them from one machine when one goes missing or gets broken. But yeah, I think depending on I don't know what the specific guideline is for measuring maternal pulse. I know that, for example, if you've got somebody that's quite low risk, that is only, for example, using a CTG for an epidural, maybe during the epidural sighting, that it's recommended to do the maternal pulse recording. But you know, it can be quite uncomfortable for the women. Some women are very much like, oh, can we take this off? Is it necessary and whatnot? But knowing when it's actually vital that we do record maternal pulse as well as the fetal heart rate at the same time is something that needs to be sort of relayed to all of our midwives, or specifically for high risk women. And
but it's not about the guidelines at that point. It's about to put it on the CTG.
Yeah, well. Absolutely.
It's not about the how often, because the guideline says how often should we do the maternal pulse during the first or the second stage of labor. But when we say the maternal pulse here or the maternal pulse oximeter on the CTG, it's for determination the maternal or fetal pulse during the CTG. It's not for the observations.
No, absolutely. I mean, we do have to look at the overall clinical picture here, and actually, had we had the maternal pulse monitor on at this point, you know, things could have gone very, very differently if we couldn't determine actually whether the fetal heart rate was fetal heart rate or maternal pulse. And obviously, it comes up in a different color on our CTG machines when these things overlap. Same way it does if we had twins, for example, on the trace and their heart rates were identical at the same time. The whole thing changes color. Obviously, it doesn't on the paper because I'm still awaiting login to screenshot these from the computerized system. I'm having to hand take these photos at the moment, but they will show up in future cases. But yeah, obviously in this situation, the maternal pulse oximeter could have really helped us to learn more about what was going on with this baby.
I think from just another point of view as well, just to counterbalance that, it's really important, obviously, not to rely solely on a machine. As midwives, I think we're fantastic at advocating for our women when they're low risk, but when they do become high risk, we still have to remember our basic midwifery skills, and that is when we're having a prolonged deceleration to palpate the maternal pulse, and we're taught the difference between what we can hear and what we can feel. So if we have a lack of potentially equipment, it's using our own skills. And I think that's something that maybe needs to relay back. When we're doing the 3-6-9 approach, the first 3 minutes, I always used to say, do a set of observations, because if you've got an epidural on board, you should have a sort of Dynamac close by. So whether you put it on then or you palpate, it can take less than sort of 30 seconds for you to realise whether we're picking it up or not. So that could be another thing as well, just to, if we don't have the equipment, use us, because sometimes we're better than machines, and that could be something that we could potentially say as well.
And in some cases, when sometimes we pick the maternal pulse, and especially when the maternal pulse is tachycardic, you can like feel that this is the CTG, this is the fetal CTG, and that would be a huge problem afterwards. That's what I meant also by that.
And one last thing to say, if you are seeing a hyperstimulation and she is, let's say, 4 centimeter, not in this case, but generally 4 centimeter with hyperstimulation, I want just to like put some thoughts, which is if she is 4 centimeter and intact membranes, would you rupture the membrane first or give terbutaline first? This is a question to my colleagues, which is very important during the management in labor ward.
Terbutaline.
Terbutaline, yeah.
Yeah. So terbutaline, excellent. So because some people say, oh, there is a deceleration, let's break the waters, then let's manage and let's do this. No. Terbutaline first, let the baby relax, let the tone relax, and then break the waters. Yes, in half an hour, in an hour time. So there is no rush as long as the baby is not in a hypoxic condition. So thank you that we are all in agreement that if it is in an acute situation, it is not the ARM as the answer.
Because if we RM'd, we increase the prostaglandins. That would
Exactly,
cause more.
exactly. Yeah.
Thank you for a really good session.
Yeah, no, thank you all for the presentation, and Cara and Sosha, thank you so much.
Thank you, Kara and Sosha. That was very interesting case.
Thank you.
And it raised a lot of key points. And
Yeah.
I insist on the maternal pulse, Kara. I still insist. I still insist, and I know it's just a point for the future, and yeah.
Absolutely. Perfect. Well, I will try and get some more interesting cases like this with some good learning points to bring to our next sessions. But yeah, thank you all for coming, and I think that was a really, really interesting debate that we had there for lots of different reasons. So
thank you. Thank you.
Will there be another one? It will be every Tuesday.
Every Tuesday, Omar. Every Tuesday.
And can I attend when I leave?
Yeah, of course you can.
Okay.
I still do.
Yeah, Sosha's still here.
Sosha will always be here.
Thank you, everyone.
Thank you. Bye.
Bye.